Okay, so the following slides will provide you with a little bit more information on some chronic skin conditions. The reason I put these into a voiceover is that these skin conditions are relatively common in the adult population as well. And if you haven't received information on these topics already, you certainly will receive them once again in your med-surg types of lectures. So the first one I want to talk about is eczema, or also known as atopic dermatitis. And this is a chronic genetic skin condition. We do believe it is due to a gene mutation that sort of affects the skin barrier and leads to a lot of water loss. It doesn't protect or hold in moisture, and therefore we lose a lot of moisture and the skin dries and cracks. It is a superficial inflammatory skin disorder. So when we think dermatitis, of course, itis meaning inflammation, that seems to make sense. This is characterized by an intense amount of itching or pruritus. 20% of infants get this, and adolescents, about 60% in the first year of life will get it. So it is a common disease process, if you will, or chronic disease process. So we will see these acute patches, and you can see those pictures there. They may have papules and vesicles, have a little bit of exudate or crusting over as itching occurs, and they start to weep a little bit. In chronic conditions, they are very darkened and thickened skin, obviously due to long-term complications with the disease process. Infants, we usually notice it very specifically in the face, the neck, or in the extensor surfaces. And as we get older, we tend to see them more in the creases of joints. So we tend to notice them in the popliteal space behind the knee and in the antecubital spaces by the elbow. Adolescents, we can see, may additionally have it close or along their eyelids. In the next slide, I do have a picture of that. And also along the earlobes as they connect to the face and between fingers, you will notice it. Itching is obviously one of the greatest concerns here and irritations here, and it can lead to really bad patterns of sleep for these young kids. Now, the interesting thing about this is that whenever I see children with eczema, I immediately think that there are allergies and likely asthma somewhere along the line. And what research has shown is that as children develop asthma, we start to see a decline or a disappearance in eczema outbreaks. And it seems that the asthma tends to take over. So in terms of treatment, as you can imagine, if this is allowing moisture to seep out of the skin and then creates these lesions, hydrating and lubricating the skin is incredibly important. And patients need to be diligent about this. And as young adults and school-age and adolescent children, this is hard to do. It needs to be a treatment that is a barrier such that we don't lose further moisture. And additionally, we may use some topical steroids to help with itching, maybe some oral antihistamines people want to try, but they are really honestly not effective for this type of itching. I have seen this in children for years, and there are some children that it gets so bad with the itching that we develop infections of the skin, and then the children have to be treated for topical infections as well as all the barriers we need and the steroid creams that we need. And so it can get to a point where it's a time-consuming process of layer upon layer upon layer of creams and ointments. And the more we have to apply, the less compliant patients and families are. So this is a tough one to manage from time to time. If children have food allergies, and as I mentioned just a second ago, most children with eczema also have allergies of some sort, and many of them develop asthma. But with food allergies, when we have a food allergy, that actually can cause worsening of that itching. So in terms of managing it, we should really be looking at what causes more flares, what irritates the skin more, are there any dietary allergies that we need to think about so that we can kind of limit those that may instigate flare-ups more consistently so that we can track that. Additionally, we want to assess how their sleep patterns are. We do know that this is one of the greatest things that students or that patients are experiencing frustrations with. If there is a family history of this eczema, what research recently has shown is doing full body creams on newborns daily right after birth may actually decrease the development of eczema later in life. So we are beginning to see that if we can treat early, we may notice improvements in these children's potential for that disease process. Acne is also a chronic skin condition. I think all of us at one time or another have experienced this. This is a common disorder. It is inflammatory. It can occur on the face. It can occur on the trunk of the body, the back. And really, basically, sebum and keratin flow to the skin surfaces. So we know that that naturally happens. But during puberty, sebum production increases. And as it comes in contact with that keratin, it creates a clumping, thickening of the combination of sebum and keratin, and that is what obstructs those hair follicles and develops into whiteheads and blackheads. This causes inflammation as that sebum mixture becomes infected. It is the most common skin disorder that we notice in children today. Between the ages of 12 and 25, about 85% of us have in some way dealt with acne. As a sidebar here, neonates can develop a reaction to the maternal hormones, and they may develop what looks like acne. It can concern parents, very concerned what's happening, but it will spontaneously go away as those hormones decrease, or the maternal hormones decrease in the young neonate's body. So for treatment, we really want to suppress the lesions and prevent infections and scarring. There are a lot of topical treatments. There are some oral treatments that are used. Topical retinoids are a big supporter of clearing up acne scarring and acne breakouts. Accutane for patients who none of the other either topical or oral treatments work for, we will use Accutane. Accutane patients need to be monitored very, very closely as there is an increased risk of depression and suicide in patients who take Accutane. This can be very concerning to parents and very alarming should a decision be made to put a child on Accutane, and so we as nurses are often involved with discussions regarding that and helping parents learn what to watch for and what to monitor for. Some things that we need to make sure when we're teaching young adults about, or young school-age kids who begin to develop this in that puberty stage and adolescence for treatment, good hand washing. As with anything, it is the first and foremost thing that we need to do. First pass for all infection control. They need to wash their face, with soap at least twice daily, and to avoid anything that may dry out the skin. Sometimes the astringents and products that adolescents put on their skin actually worsens the condition because it dries out the skin. And when we dry out the skin, it actually tricks our body into saying, oops, we've lost moisture. We need to increase our production of sebum, and therefore the process actually worsens. Picking or squeezing is bad, can cause infection, and can cause scarring. I have seen young adolescents admitted to the hospital for sepsis as a result of picking acne scars and pimples, causing them to become infected. So it is not a pleasant thing to tell your friends you've been admitted because you were picking your zits, if you will. Topical treatment needs to be thin layers, not thick. We tend to believe more is better, and that is not true. A nice thin layer is best. Adolescents will often ask what foods. There is a belief that very oily and fatty foods cause acne. That is not true. While there are no known foods that cause acne or worsen acne, a good healthy diet we do know actually can make those breakouts a little less in terms of their severity. As we use treatment, condition does get worse before it gets better. Young adults and adolescents need to know that. And most of the treatments we use make one photosensitive, and thus we need to really reassure and ensure that our patients are using sunscreens whenever they are outside. Finally, we all know or young adults with severe acne really often deal with the psychological impacts of that as well. And especially in that adolescent stage where we are concerned about how we appear and how we appear to others, this can be a real difficult thing to deal with and something we need to address. Psoriasis is the last chronic condition, and you can see we often see psoriasis on the skin, the scalp, or the nails. It is autoimmune, and it leads to a thickening of that epidermis and develops those plaques like that picture on the left there shows you. They're very scaly lesions. They can sometimes be very thick and have a silvery color, and in the next slide you'll see more of that silvery color. But as with many autoimmune disorders, flare-ups are caused by stress on the body, stress on the system. So when patients are going through excessive stressful times, they may notice an increase in those flares, either in their scalp or along their joints especially. Psoriasis, and you can see that silvery texture to that on the left there in that photo and this is psoriasis of the scalp. There are several treatments that we will use. There are tar shampoos, many available right over the counter that many patients find relief from. Topical steroids, vitamin D is also very good for the skin in terms of healing psoriasis breakouts. Some patients will need to have some drug therapies for this, although most tend to be able to handle it with the shampoos and some of the topical steroids and creams. Patients need to know this is not a contagious skin disorder, and there will be periods of remission where there are no indications of psoriasis, and then, as we indicated, those flares, often triggered by either illness or stress on the body, we will start to see those flare up more. This is a major mental health concern, as is acne with young adults and adolescents, and something that we need to very much pay attention to, focus on, and really enable them to know how to manage not only the condition but also the stress. So teaching mindfulness and yoga and methods to help them decrease stress will certainly help with the outbreaks. The last thing I briefly want to talk about are lesions that can develop and skin reactions that can develop as a result of drug reactions. So it is relatively common for patients to have a sensitivity reaction to drugs. Most common drugs would be your sulfonamides, your antibiotics, and even anticonvulsants. And they will develop most often on the trunk to start. An erythematous rash really looks like hives, and that picture there is a pretty good picture of what that looks like, and those hives are very itchy, and again you can see this is on the trunk. This can occur either right after the first dose or two, but could actually not occur until about 7 days into a long course treatment. So oftentimes patients aren't looking for it or expecting it days into treatment. And anytime a patient begins a medication like a sulfonamide or an antibiotic, and they call us and indicate that they have this rash on their chest that they noticed maybe while they were showering that day, and it had been 3 or 4 days into their treatment, we need them to stop taking that medication and come in for an evaluation, because there is a concern that they could further develop complications, and of course we don't want them to end up with an anaphylactic reaction. So first sign is usually this skin condition. We stop the drugs and often can give antihistamines and topical steroids to alleviate the rash itself. There is a condition called Stevens-Johnson syndrome. This is actually a potentially life-threatening condition, and it is a reaction, a prodromal infection that results after treatment or with treatment of certain drug categories: penicillins, sulfonamides, cephalosporins, NSAIDs and acetaminophen as well, but most commonly in those 3 categories of antibiotic treatment. And this leads to very painful sloughing off of skin on the lips, the oral mucosa, and the entire mucosa of the respiratory system and the GI system. This is extremely painful and uncomfortable. It is almost like partial thickness burns, but if you can imagine that working its way all the way down the respiratory and GI mucous membranes. You can also get some corneal blistering as a result of this, because that is a moist surface area, and blindness can eventually result. This is dangerous. These patients need to be admitted. Many of them are in the ICUs, intubated for periods of time. This is dangerous and very rare. In my 33 years of practice, I've seen this once. In a young child who did survive, but incredibly painful experience for that child and family.